So touching the medial side of his leg is much more sensitive than the lateral of the sole. Whereas there's not much here. So a little bit on the sole. Take your time to examine these patients, because it was the fact that we took time that the diagnosis became evident. Watch them do what they say they're having trouble with doing. The patient says, I can't put on my shoe. Watch him put on the shoe. And it's in fact affects the right side, although he didn't complain much of the right. But it's easier on the right. Watch him try to do it with the left.
Okay, do that one more time.
Sure.
Hands will be symmetrical. It should take them off.
So again, you're tempted to say this is ataxic, but it isn't, and I can tell you why in a minute.
Take that one off.
Yeah.
Does anybody know what the movement is for?
Right.
But it is myoclonus.
And then put them on again and be done.
So this is stimulus sensitive, sensory stimulus, and action induced myoclonus. So this is probably a cortical form of myoclonus. But it's very selective in its lower limbs, which is especially interesting. You'd have no trouble getting the diagnosis if this were generalized. But it isn't. And he spent about 5 years, I think roughly. He can walk well, but in certain times, especially remember coming downstairs, I think we actually showed him coming downstairs. He can do all of these things well without trouble. Here we go.
Okay, come on back up. Okay, come on back up.
So he can climb the stairs normally, but he has to go downstairs one at a time because of the jerking.
Try leading with the left.
If he leads with the left, it's especially problematic for him. So again, examine the patient and try to do the things that the patient complains of. So, importantly, several years before I saw him, he had had a cardiac arrest. Multiple organ failure was in for 11 days, and then awoke from the coma, had some seizures, and then, as he's recovering in rehabilitation, it's noticed that he has this problem. And everybody thought it was an ataxia as a consequence of his brain insult when he had multiple organ failure. In fact, this is a form of very focal post-anoxic action myoclonus. Very responsive to treatment. We put this man on a little bit of clonazepam and valproic acid, and he is entirely normal. I saw him 2 weeks ago, and I see him once a year, and he hugs me, because we gave him a normal function. And it was only recognizing that this was a form of action myoclonus that we were able to make the diagnosis. Very treatment responsive. This is a patient that came to us with very severe myoclonus. Now he obviously has more than that, but just watch what happens. He has Parkinson's disease, and quite late stage Parkinson's. The family have been dealing with his disability with difficulty, but the problem you're going to see has become the major problem. We'll just ask him to stand for a little while, and then he reaches a point that he can no longer stand. We get him back down, and it continues. If you lie him down, will he stop quicker?
And it's triggered the something is happening.
Mom wants to get in the way as someone pushes her because she knows it's being filmed. So I think the diagnosis is sort of given away by what my fellow is doing. And in fact, this is severe generalized myoclonus as a consequence of orthostatic hypotension. This patient's blood pressure fell terribly when he stood up. It continued to fall while we kept him up, and that's when he started to jerk. And what was interesting is even sitting down again, he still had enough cerebral hypoperfusion that the jerking continued, and that was the major source of disability. All we did was treat the hypotension. Remember, orthostatic hypotension may be a cause for falls in more mildly disabled patients than this. This man can't walk by himself, so he's beyond that. But if you have somebody that's still walking and getting that degree of drop in the blood pressure, that's why they may fall. He did beautifully by just us treating his hypotension. We gave him some fluoronephrine mitidrine, I think it was, and he did very well, and the family was very pleased by the fact that we had an impact on his care. And this is, I think this might be him. I don't know whether this is more afterwards or another episode. You'll be able to tell by what happens, I guess. Yeah, I think this was after treatment, and again, he's, with a little bit of help, he's able to walk, and they're very happy he's getting none of these jerks at all. Okay, how are we doing for time? Maybe one or two more cases, or should we stop? Keep going? Okay. This is a brother-sister combination that I've been following for many years. The brother, no past history, he's on clonazepam now. His sister has ADHD at the age of 18, and they both live together with their family. And this is the boy. Tongue tremor, really important to look for and consider. And this sort of irregular tremulousness, usually symptomatic of a variety of different diseases. Is sort of pulled back a little bit. I think Wilson's disease, the sardonic grin of someone with Wilson's, but that's not what he has. He's got some dysarthria. What happened there? I hit the... Why is this not working now? It's not working. Sorry, it's revolting or rebelling. It says, it's after 4 o'clock, I need to go home. Yeah, let's see if he works this time. He's not going to work. Oh dear, I don't know why that's not. It's blind. It's a very large very large file, and I'm not sure, this hasn't happened before. Okay, why don't I get out and I'll just load it again. But let's Actually, I'll show you. I'm going to show you a couple of other ones, just very quickly, and then we'll stop. This is a woman that came to me many years ago.
In your mouth, too, or stuck in a certain position or something like that?
And she began with right hemidystonia and had a left thalamotomy by a very good neurosurgeon. She recovered beautifully. Then her right hemidystonia recurred. The surgeon did another thalamotomy, at which point she developed severe generalized bilateral dystonia. She had been treated with high doses of anticholinergics before she came to see me. Okay? This is her when I first saw her.
And you had the
Now, one-
thalamotomy when?
October 84,
And then another one,
December 84.
and those were both probably on the right side. And for the left side.
Got the two sides.
Look upward, behind you. Look to the left.
So asking her to look up causes a severe dystonic spasm. Her arms
So looking
go
up.
into posture, the head goes back. She is essentially wheelchair bound because of this dystonia.
Can you pull your head down now? Open your mouth.
An important feature is the posture of her face, pulled over to one side.
Stick out your tongue.
And this behavior, attempting to push out the tongue with more pulling to one side, is unusual.
Put it back in.
And then she starts to shake her head a little bit. Now look at how the face is now relaxed. As we attempt to get her to use her upper limbs, she has more dystonic posturing in the arms. She's trying to do heel to shin testing now. So you have no trouble with the phenomenology here. This is dystonia. The history. This began in adult life and became generalized fairly quickly, especially after the second thalamotomy. That was unusual, given the fact that the thalamotomy was done on the ipsilateral side to the subsequent development of dystonia. The facial pulling over to one side, and then when you get her to do something, it seems to relax. The precipitation of the dystonia, when I ask her to look up, she gets into one of these bad dystonic spasms. When you have enough experience with this, the primary dystonias or the pure isolated dystonias, DYT1, etc., you don't normally see this kind of behavior. And so I thought this was probably a psychogenic or functional dystonia. I admitted her to hospital and I said, you have dystonia, but I think if we give you physiotherapy and stop the anticholinergics quickly, things might improve rapidly. I tried to suggest benefit. And this is the same patient, if I can find the video. can't hear this, no sound of this now, but this is her 4 days after coming into hospital. So she was basically cured. She had a little dystonia left in her hand, and I bet that was due to her thallomotomy as a consequence of the surgery. So functional or psychogenic dystonia is a real entity. It's rare. Don't overdiagnose it. So when you see somebody with generalized dystonia, this should be the last thing you think about, but it should be in the differential diagnosis. And it's very important, as remember I told you, there are good groups that are now doing deep brain stimulation on patients like this. So it's very important for you to know that. Should I show you one? Oh, this is an interesting man. In the United States, there was a period, it's just finished in the last couple of years, where professional welders were told that welding with welding rods that contained manganese would cause severe brain manganese toxicity, manganism, which is an important neurological disorder, right? And I think you've seen manganism in this country, and certainly in Taiwan, there have been workers in manganese factories that have been come down with very severe dystonia, Parkinsonism because of manganese toxicity. So these welders are suing the companies in the United States for manganese-induced brain poisoning for millions and millions of dollars. And I got involved seeing some of these patients on behalf of the defense. And so I would exhibit some of them. And this man was said to have manganism. He had been seen by 3 movement disorder neurologists. They said he would be wheelchair bound and they should settle for many millions of dollars in his favor. So he had a tremor, which can occur in manganism. But I want you to watch the tremor and its behavior in response to different activities. So look at his right hand as his left hand is doing that. I'm doing proprioceptive testing here. So it's very important to watch the patient at all times. So he's shaking like this, but then when he does a finger to nose with the left hand, the right hand settled down. Remember, he's shaking like this. I'm now getting him to pay attention to my proprioceptive testing in his foot. Where's the head tremor? It's all gone. I'm in training. Watch what happens to his head.
Okay, I'm going to give you a good game.
I do a very minimal pull. Horrible postural stability. Okay. So, this man was seen, like I said, by other movement disorder specialists. He actually had very detailed electrophysiology at a world-renowned movement disorder center. And they said he had a really unusual form of tremor due to manganese poisoning. But he was presented as having manganese poisoning. The detectives went after him. So I was suspicious. I told the lawyers this man is functional or psychogenic. But it's not just a conversion disorder, this is a malingerer. So he lives in a farm, and the closest that anyone can get from the road is a long ways away. So a detective sneaked through the bushes with a camera. And this is the man who was in a wheelchair, who was going to be disabled for millions of dollars. He's working his fields and raking. One of the experts on the other side was shown this videotape, and he said, oh, well, I guess the patient was embellishing a little bit. But see, he still isn't swinging his right arm as he's walking. I want you to notice why he doesn't swing his right arm. He's carrying a case of beer. So it's a good reason for not swinging your arm if you have a case of beer. So rarely are functional movement disorders malingering. They are very different. Functional neurological disorders are usually patients with what has been often called somatization, conversion disorders. These are not voluntary, they're very disabled. We need to understand them much more than we do. And there is now, to begin with, beginning in January, an international functional neurological disorders group that is now beginning, syndrome or whatever, an international group of experts that are specializing in this area. So this is not a psychiatric disorder. Malingering is not a psychiatric disorder. This is somebody doing it on purpose for obvious primary gain. So I think I should stop at that point. Shouldn't I? Okay, thanks for your attention.